Nancy,
I'm sorry, what?
please.
Your slides? Yeah, hang on.
Yeah.
It's unverified thing.
That they weren't invited and it's a email address that they didn't have any information about.
We can go ahead and start if you want more waiting.
Sure. Thank you.
Yeah.
Well, good morning. It's January 27th, 2025, believe it or not. And as the chair of the Prescription Drug Affordability Board, I'm calling a meeting to order. For a roll call, Gary Merchant, chair of the Prescription Drug Affordability Board.
Bob Woodward, alternative member.
Cindy Rosenwald, Senate District 13.
Jason Azes, Director of Health Economics, New Hampshire Insurance Department.
Thank you. And is Todd here or any of the other board members? Okay. So for today, I would like to elevate Jason as a full board member along with Bob, which will give us 4, creating a quorum. Take it away.
Nancy, you can go to the next slide. Okay. We'll review the minutes. Okay, right now we'll go ahead and review the minutes. Do you want to make a motion?
Make a motion to accept the minutes as published.
We have November.
We don't have November minutes. We,
Okay.
Yeah, we had an issue with Microsoft Teams,
Then
so we're still
I'll
working on
second
them.
The motion on October 3rd.
Thank you. Any discussion on the minutes? More of a comment for this discussion, somewhere along the way, you have in the minutes that you and President Edwards are going to have a discussion about the MOU?
Yes, we met with Melissa St. Cyr. And we essentially cannot expand it to include another agency. So we had that need to do a separate MOU with the Department of Insurance or any other department that we'd like to, but we can't expand this one too.
Can't use the one. Okay, thank you. All those in favor of the minutes?
Aye.
Say aye. Anyone opposed? The ayes have it. Thank you.
All right. Okay, Nancy, can you go to the next slide, please? Actually, the next 2 slides. You can go to the next one. Okay, go back 1. I'm sorry, it's hard for you to see. You have it in your, in the slides in front of you.
Can we make that? We should make that larger.
Make it small.
Nancy, can you make that slide a little larger? The font on it.
I'll try.
Okay, while she's working on it, as you know, we're going through the biennial budget process. We submitted our budget, last fall. These departments have been working on their budgets for many, many months. What you'll see, what I want to point your attention to, there is the efficiency budget and there are prioritized needs. Cinder Rosenwald is probably the best person here to talk to all of that. Essentially, the efficiency budget is what we need to get by. What our current budget is, and assuming we get no extra funds, is the way we would be able to run efficiently. Prioritize.
Another question.
Go ahead.
Does that include the state employee raise?
That is inclusive.
Okay.
Yes, ma'am. You will see that my line item essentially goes down for FY 26 and then back up in 27. That is that still gives room for raises or et cetera. I don't make that, it just gives the room for raises. But anyway, the efficiency budget, that is essentially what we need, assuming we get no extra funding. The prioritized needs, I prioritized additional funding for contracts for program services. It's unlikely we will be able to hire somebody, given kind of like the current outlook of the budget. So to bring on additional staff for this work, it'd be great if we could increase the funding that we have for contracts, and I'll give a little bit more on where we are with the current contracting process in just a little bit. And then you'll see that it holds steady, the same in 27, and then the prioritized need for 27. Do you have any questions before we get into it? Yes, sir.
The one change between the adjusted authorization column for 25
Mhm.
and the 25 efficiency budget seems to be benefits. It drops from 54.7 to 39.9.
Mhm. That's done by the Department of Administrative Services, whatever the benefits may be. So for last year, the actual benefits that they paid out were less than what they needed. And so for this year, whatever it's what they authorize is 54, which it may not end up being 54. But that's what they have authorized for. And then based on the guidance from DAS, we put in it's 39 for the next year. It may be more, it may be less, but that was the guidance we were given.
You're happy with that?
Well, I mean, I can't really say anything.
Okay.
I think one of the things too is the out-of-state travel. We had, before we went to fiscal
Right.
committee and the governor's council, to move some money from contracts into those line items so that he would have the ability to submit reimbursement for his travel when he's doing the state.
Right.
Also out of state, there's some educational things that we agreed to. But before we only had like 3 lines. We had to go back to the fiscal committee to expand. Maybe Cindy can help us out with why we had to kind of go through there. Because if you don't have a line item in your budget, you can't put money into it. Yeah. We only had there's 3 lines. I think we had to salary, benefits, whatever it was, and contracts. We didn't have anything for out-of-state travel and state travel and so forth. So we had to go back to fiscal to create the lines in the budget in order to move the money from contracts into those lines. So what happened was in the one before, it has 0 there because there wasn't anything there. It was all in contracts because we only had 3 lines to play with.
Gotcha.
So,
Looks like Todd joined. Just so you know.
okay. Good morning, Todd, Mr. Pay.
Good morning.
Good morning, sir. Thank you for being here. So that's so if I understand what you're asking for, most of it is in maintaining what we have. We're
Right.
trying to expand the contract line, and
Right.
you'll go into more of that detail to what we're trying to
Right.
accomplish with the contract. line.
Yeah.
That's good.
All right, can you go to the next slide, please?
Can I just ask a question?
Yes, of course.
About this. So it's all general fund
Mhm.
because while Representative Edwards thinks we only suspended,
Mhm.
in fact, we repealed.
Right,
So we're dependent
right,
on general funds
right.
unless we decide legislatively to go in a different direction.
Yes, and you know, we're working to establish the PDAB fund. That may take some time. And still, I don't think initially, at least for this year or next, we could count on voluntary funds. But that would be another area where we could think about supplementing general funds if we were to get a grant or if we were to get some sort of donation of sorts. But right now, yes, we are 100% general funds.
So could I just follow up?
Sure. Yeah.
So there's more money in the budget, in the benefits line than is actual. That money, that extra money
Mhm.
will lapse at the end of the biennium
Right.
unless we put something in House Bill 2
Right.
that creates this fund and puts that money into it as a starter.
That or because we are lapsing, if this became non-lapsing. So if we were able to
Right,
roll
we
that
could-
funding over to the fund, yes.
Right.
Right.
But it would still be in the benefits.
It would still, yes,
Unless we move.
unless you moved it, right?
So we should think about that by
Absolutely.
maybe something Rep. Edwards wants to do in the House phase.
Uh-huh.
Or otherwise, we can look at it during the Senate phase.
Okay.
Start April.
So, so basically, I like where you're going, but trying to understand it. In the non-lapsing, is it the total amount at the bottom that gets, or is it line by line it gets rolled over?
Well, it's line by line, basically.
So therefore. the
So if
20%,
it's in benefits,
Yeah, it rolls into,
it goes back to the state. And it would end up on the surplus,
so,
but we can suspend or change stuff like that in House Bill 2. So if there's money and benefits not being spent,
Mhm.
rather than returning it, we could just make it non-lapsing, but it would stay in benefits.
Mhm.
but we have to. But just make it a non-lapsing won't roll the money over completely. We
I
have to
don't think
somehow.
so,
Okay.
because I think it would stay. I think it would depend on how we wrote it. But Lucy Hodder would probably know that.
Yeah.
So, bring me up to speed on, I think this conversation had to do with what you call the PDAT fund, which is the voluntary contributions. Can it be rolled into, can that PDAT fund be started with the excess benefits?
Yes, because you could write it as contributions from any source,
Gotcha.
That's
public, private.
would roll into it if we get a grant, if the rule written for the grants. Or would we have to do that? Can we just roll it into a grant fund? I think it's
Well, a non-lapsing fund to support the PDAT.
right.
But I don't see why you couldn't roll this extra benefit money in.
Mhm.
And it's not very much
Not
money,
No,
but it's not $1 either.
Right.
But it would also get the PDAT fund started.
Right,
I mean, right now, there's no fund
Right.
for it to go into.
right.
Right.
So
And the,
Unless it was held, if the PDAP itself was not lapsing. It just wouldn't roll over to the fund. It would
when you say the
just be
PDAP
non-lapsing.
fund, can you clarify what that means?
the contribution, the concept is we're starting a fund into which anybody could contribute to the progress. That we may not pick on anybody in particular, but AARP, for
Right.
example, has been supportive.
Right.
It would not be impossible that they would want to be supportive of PDAB activities and make a contribution. But right now, they could not, because there's no fund into which they can make it.
No.
One of the issues you brought up was that the fund doesn't exist, and it was kind of ambiguous of when that was gonna get started,
Mhm.
and the details of how that gets started, I didn't understand.
Mhm.
So it sounds like putting something in House Bill 2, if that
Yeah, that would be House Bill 2.
would be possible to, in one fell swoop, create such a fund and put the excess
Mhm.
benefit into that fund instead of letting it lapse, go back to the state.
So Cindy, do we need to have legislation to create the PDAP fund, or I think we already
Yeah,
have
that
it?
would be House Bill 2.
Well, we already have a PDAP fund.
We do.
Yeah.
Mhm.
And-
Right.
Can it accept funds from
We don't have the rules established yet.
any sources though?
Say that again?
Can any sources go into that fund?
Well, see, that's why we need the rules. Yeah, we need some guardrails around who can submit, how they submit.
Oh,
how we would use that money.
let us take away, is find out,
What that fund looks like.
Yeah.
Can you get
We
that to
can.
us?
we'll get that
Okay.
for next meeting. And I will talk with Representative Edwards about the possibility of taking the excess, if we can, roll it into that fund.
And make sure it's non-lapsing.
Yeah.
Thank
you. Okay. Just wanted to flag for legislation, not expecting it to be a crazy year, hopefully on the legislative front. I didn't have the bill numbers when I created the slide deck. They do now have bill numbers. The two are HB 570 and HB 645. I'm trying to map it here. Okay, so HB 570, that would fix the issue around public payers, to clarify that the authority of the PDAB is to examine not only the state employee and local employee health plans, but also Medicaid and corrections. It would also extend my position and then change the board chairperson election from every 3 years to every 2 years. And then I'll go to the next one and then just see if you guys have any questions. HB 645. This bill would allow us to work with another agency such as the Department of Insurance for all of our data collection needs, essentially leveraging their data calls in case we needed to collect data directly from manufacturers, PBMs, et cetera, in the course of any of our reviews. It would also repeal a few sections, one on transparency, really around the transparency requirements that was established, that was basically saying that manufacturers by a certain date needed to submit data to us, as well as certain payers. That is being repealed. We do already have a high-cost drug program that exists with the New Hampshire Insurance Department, so they do already collect that information. So I believe that this is in response to the redundancy report. But it helps to clarify how we can work with other agencies to gather the data that we need. I'll stop there and see if you all have any questions.
One of the things I like within the bill is on page 2, lines 11 through 18. But one of the things we talked about before, trying to follow what Edwards was trying to do, is that the board can create a data call, what data the board needs from the various entities. So what it does is it moves the collection of the data from the board to a state agency that collects data today, that has the infrastructure to collect the data. What it allows the board to do is create the data call. Is what data does the board need in order to meet its mission? More importantly, though, is that if you have a data call, but no one responds to the data call, there's no compliance. So what this does is allows for a compliance issue. So if you make a data call, but the entity doesn't respond and submit the data to the board, there's a consequence to it.
Which is,
Lines 11 through 18
Yeah,
on page 2.
yeah, we don't, I
Oh,
still don't
Oh,
think it.
here,
Yep.
yes.
so it's basically
Section-
be
What's
It's
that?
on, it's on section, it's on page 2. It's in section 2. G. I
well,
think it's important we have some sort of a consequent enforcement mechanism, because otherwise, if you don't have the ability to enforce something, you really don't have anything to begin with.
so one thing we could consider, instead of putting those fees into the general fund, isn't someone bringing an amendment to put it into the PDAB fund?
We could.
Budgets for the line.
I wrestle with that because what I concern myself with is that if any board uses compliance or penalties in order to fund the board per se. But since this is something that's really black and white, it's something that they're responding to. It's not like you're enforcing something. like I know in the Board of Pharmacy would have inspections and then people would write up tickets, the same thing like the law enforcement writing speed tickets just to build a fund. That's what I'm trying to avoid. So
Right.
since this is something we're not doing ourselves, we're really relying upon the other person's non-compliance in order to provide the funds. I could build it.
Maybe you would bring in men.
I could talk to Jeff.
I'd like to understand better to what extent, the executive director brought up an MOU, a separate MOU, presumably, I mean, the insurance department, we do. So to what extent does the board's data collection, are the data collection needs met with data calls versus an MOU versus a 91A request? I think the drug rebate data that we anticipate getting this year, pursuant to Senate Bill 555's passage, seems to be is gonna be much more granular, and the department is fixated on ensuring vigorous compliance with that. As such, we expect pretty robust data reporting. As it stands now, that the public access to that data is pursuant to 91A requests, and we get many for that data. But then I've heard other versions, like with an MOU or this section in the legislation, and I'd like the board to chat about that a little bit, because there are several permutations for which I mean, that's information for that can be made useful to the board. But there are a few legislative mechanisms, it seems, on the floor right now. I think it would be best for the board to talk about that in the interest of clarity and avoiding unnecessary legislation.
I totally agree. I think one of the things we talk about, again, redundancy, we don't want to have a data call going out to different entities from different state agencies asking for the same data. But at the same time, if there's going to be a state agency, whatever the agency would be, or the entity, that if the data call that they have is not meet the requirements of another entity, the other entities have the ability to augment it and saying, yes, you've collected 10 data elements. Of the 10, 8 of them I can use, but there's 2 or 3 other ones that are not in your data call. So it should be something that's done synergistically. And I think also when the data comes in through an MOU, is that different entities within the state can share the data. And not have it say it's only in one entity only, but we're having the ability to collect data within the state in some capacity. I think it's important that we have the ability to move that data from one to the other, as long as we have an MOU, understanding how it has to be protected. Does that make any sense?
It does. My point is that the opportunity to do that seems to be in the legislative cycle, to get a statute, because that's the most robust approach to ensuring the access to that data, whereas data calls, we do many of them, can be spurious, and compliance across all of the entities of interest varies mightily.
What would you recommend, Jason?
Well, we just entered the current legislative cycle, so if Representative Edwards is amenable to augmenting that in this piece of legislation, I think a few key elements were stripped away in last year's legislative cycle with Senate Bill 555. But what we ended up getting was really good enough and better than most states. If it's insufficient for this board's use, then I suggest we address that in this current legislative cycle.
Okay.
Data calls, I don't think are the right mechanism for that. So let's consider what elements aren't currently, we're not currently getting through Senate Bill 555 from last year, and see what else is there.
Can you
Recall that the Federal Trade Commission has had very poor luck and success getting these same data elements. So I think we need to consider pragmatically in the good, better, or best paradigm for the board's use. So we can start acting on our missive.
Can you provide some recommendations for us to chew on and talk about and so forth? But I think it's important particularly for Mr. Williamson, that if he goes to the legislative body and speaks on behalf of the board, he has the support of the board. So he's speaking on us collectively versus speaking as an individual.
Absolutely. The insurance department is intent on informing this board, especially on how successful we are getting reports from the PBMs through their license or renewal process at the insurance department. And I think March 1st, Morgan, is the deadline for the submissions of the annual rebate summaries. We're hoping that we see strong compliance, and our commissioners committed to enforcing conditions of non-compliance in the event that we don't. And that's when we can really, help inform the board on what additional data needs or pressures we need to apply to get them.
Within the statute today, what is the consequence for non-compliance? So if they don't submit the data by March 1st,
It's $2,500 per violation.
Is it up to a certain amount?
There's not a cap,
Okay.
and I think the initial legislation was 10,000, and
You removed it.
pressures brought that back down, but given the many, many domains across many, many actors,
Right.
that's a substantial amount of money that the goal isn't to really generate revenue here,
Right.
it's to get compliance and transparency, which I think is aligned with what the board's targets are too.
But I think we are also not just interested in rebate data, but you could envision a world where you may want information right from the manufacturer. You may want information around R&D, or you may want information about what their expected market share or expected market share over 5 years, or they intending for it to be in New Hampshire. So I'm thinking that we may want to leverage you all for that process. I'm not just thinking rebates, but I do agree that maybe one thing to consider is making it clear in statute, maybe that the insurance department can share the rebate data collected under SB 55 with the PDAB, or, for in the event that it wants to review certain drugs, or I don't, whatever the language needs to be.
So my understanding right now is that the data that is expected on March 1st is at the granularity of the manufacturer and the insurer. So if we take Medicaid, for example, the number that Medicaid would report, if they're included in this as an insurer, would be all the rebates received dollar-wise for all the drugs provided by any particular manufacturer. Let me go on and say, it doesn't include by drug,
At the NGC level.
right? It does not include anything at the NDC level, right?
It does.
It does. So, does that allow us to identify areas where an insurer has opportunities to provide cheaper drugs? I mean, our concern is that the PDABs are putting an expensive drug on their formulary because they're getting a big rebate for that drug. Is the current data capable of identifying that area or that difficulty?
That's a really good question. And so the rebate data you're referring to is pursuant to 402N, which is the PBM rebate data. In of itself, no, but as an adjunct to other data that the insurance department gets, some of which is not at the current time disclosable, are drug formularies, which we review extensively. And Morgan Harris is here for that. We review that, and that second piece can be an adjunctive data set for us to evaluate that. Now, that as it currently stands, that is proprietary data. We can't disclose it unless some bright legislator were able to make a law get passed for that to be transparent. And we, our unit aims to have that level of transparency. We too, like many other actors in the state, are constrained by some of those statutory confidentiality arrangements.
So there are two issues. One is the confidentiality issue. The second is the data sort of accuracy or drill down or granularity. If I'm understanding what you're saying, you're using one data set to kind of imply, to estimate what the drug level rebates are.
Right, I would say in reverse order, we get the drug formulary submitted to the department and we do extensive reviews on them across tiers to see if there's adverse cost sharing, anti-tiering conduct. And we can see that with a lot of in-depth analysis. Then in turn, we may look back to some other data, such as the PBM rebate data, to see if rebate generating potential is the main driver for that adverse tiering.
Yeah, so I'm used to teach Medicare cost reports. I mean, one of the questions is what the costs really are. And Medicare does a fine job of estimating what the costs are using a variety of methods. The problem is, of course, that those data, that algorithm can be generated. That is, if you're trying to figure out what the cost of laundry, you allocate the laundry based on the incoming weight. And if for Blue Cross, you allocate it based on the outgoing weight because of the continence problems or incontinence problems of the Medicare patients in general. And you end up getting costs for the laundry recuperated or remunerated more than the actual costs. So the game's to be played. I worry about the allocation process. And if the senator and perhaps we can, our House members can get to the granularity and the availability of even your estimated rebate by drug, it would be useful to be able to have access to that information. Because right now we're flying blind.
Yeah, I agree.
And I think the Department of Insurance's point of view is we'd like to provide the data, but we don't have the legislative authority to do it. So,
Yeah, I would rather not get the governor, our commissioner, members of the boards litigated against in a very litigious environment.
well, there are a couple of issues. I mean, one of the questions is whether the state, and you're right, you're quite right. The current environment may be such that it's not going to be possible for the board to be informed to make decisions, but.
And I think that's one of the things that, but listen to what Jason's trying to get to, Bob, is that the way this statute bill is written is allow the board to do a data call. The problem, I think, what I'm sensing is that if the insurance department's collecting the data and they have it, but they can't share it, then we either go back to legislative body and saying the insurance department can share it with us, or we have to go out and have our own data call because we don't have the ability to share it. That creates redundancy. So if we're really trying to get rid of redundancy, then I think legislatively, if the insurance department has the data, then we need to go to legislative body and saying, we minimize redundancy, is to an MOU, and we allow the department to share with us.
And would have to have the same confidentiality
Yes.
protections,
Otherwise,
because we could never share it. I mean,
Oh, no,
then-
no.
we couldn't in the aggregate, but you could never
Yes.
do it. Yeah.
And you could meet in an executive session, but you couldn't, but you would not, you wouldn't be able to talk about it outside of it.
So
I
Jason,
mean, I think one point is clarifying, the data collected under a data call, but what would be shared. And I think there's another issue of the data that they are currently collecting from PBMs, to the extent to which that can be shared, and that can be clarified in statute. Yeah, and I think, like I'm saying with leveraging data calls, you probably will want to look beyond just PBMs. And we would leverage the insurance department to do that. Or work with them to do that. But we aren't so far in a process where that is like very easy to understand. But we wouldn't be in a position where we want to look at the net price of every single drug. We would want to look at the highest cost drugs and then evaluate what their net prices are, and likely their high cost branding drugs. And so we do want to see what those net prices are if you're going to make an affordability determination at some juncture. I see those as the three things that this legislation might need to change to reflect, but I think a lot of it is in there. And part of it might be clarifying with Representative Edwards if that's what he was intending to do. Because it seemed like he wanted us to leverage the insurance department to do a data call. He probably didn't think, well, I would want them to hold it and not give it to us. So maybe it's.
I don't know whether he's even aware of the fact that.
Right.
That the insurance department is prohibited from sharing.
Yeah, across the continuum of data elements, for example, the QBM rebate data,
Mhm.
that the public could access that. Indeed, they have through a 91A request. So that, to me, seems sufficient enough mechanism for the board to get it also.
Is that NDC level?
Yeah, that's the data that's part of the annual rebate summary in the form that is submitted now per Senate Bill 555.
But is that, can the board get it at the NDC level?
Yeah.
By drug?
Yeah.
We can. So we could have an MOU with the insurance department, get that data.
Well, an MOU, like I said, an MOU would not be necessary for that.
He's saying you would do a 91A request. Yeah,
But that's perhaps not the most efficient way.
Doing so.
Right.
So
I mean, the board has to do a 91A request
Yeah.
of the insurance department.
I mean, we get them from the public often, so I'm not sure about legislative efficiency. It seems like MOUs are not inherently efficient either.
well, an MOU to me is like, I understand it, Jason. I hear what you're saying is that an MOU is like getting a 91A, but it's a global, it's long acting. It's, you're not doing one for every single time you want something.
Hmm.
So
And if there's a 91A request, you only have, what, 10 days?
Yeah, and so this was the first time I've heard that a three-way MOU with HHS and the insurance department is not amenable. And so Commissioner Betancourt is open to other options. So let's not think that, he came on here, he tells us reiteratively that, we are to support the board with their data needs as long as it's legally possible. So if we need to get an MOU and that's more efficient, then I know Commissioner Betancourt would be willing to support
and
that.
I would add that the legislation instructs us
Hmm.
to enter into an MOU with
Yeah.
the insurance department.
We have
But it
three-way.
does all of,
We have three-way MOUs with HHS, the Attorney General's office, Department of Justice, and the Insurance Department. So that actually came as a surprise to me that we couldn't do
Mhm.
that. But in either case, however we agree to support, the commissioner has openly and iteratively, allocated our resources to do that, for sure.
So if is my takeaway then to make time with you, the commissioner, Mr. Williamson and myself to sit down and talk about the parameters, if you will, the framework of an MOU, at least how we get the data.
Yeah.
okay, anything else on legislation? Thank you all, appreciate the discussion. Nancy, can you go to the next slide, please? And then the next one, please. Great. So a few quick updates on an administrative side. Following our last meeting in November, you all gave me the green light to go ahead and work with the contracts office to get a contract in place to help us develop a process for examining spending annually, developing spending targets, making recommendations and the like. They have been incredibly helpful, and I just want to give specific people shout outs. Robert Moore, Erica Bresson, Brooke Provost, Jennifer Olson, and Ryko Mello. They've all been very helpful in this entire process. Wonderful people, just want to call them out. I'll have another meeting with the contracts office this week, and then we hope that we'll be issuing an RFA in the next 2 weeks or so. Our goal is to get an executed contract done by June. But as a reminder, our contracts not only have to be reviewed by the governor and council, they also have to be reviewed by the fiscal committee, which was inserted under HB2.
Which is,
Yeah,
we don't do.
we may need to suggest that as part of maybe an amendment to the legislation, one of these.
Fiscal committee or executive committee?
Fiscal,
Yeah.
which doesn't review contracts.
We're the only,
Right.
but then it would have to be reviewed by the
Executive council does,
council, yeah.
because those contracts are really an executive branch function,
Right.
not a legislative branch function.
Right.
So I hope one of these bills is taking out the fiscal.
It doesn't say that. So we would probably like to recommend it as an amendment.
Yeah, I thought he was gonna put that
I
in.
thought that was gonna
because
be in there.
He didn't understand
Right,
when he did it, that fiscal doesn't include contract.
right. Yeah, okay. Regulatory updates. I'm trying to work with Robert, Robert Barry, to establish the PDAP fund. Gary and I will meet with Commissioner Betancourt and Dr. Aziz around an MOU for the New Hampshire Insurance Department. And then just to flag that our MOU with the Department of Health, Human Services, that will need to be, I guess, amended, or it expires in June. So we just need to refresh that and incorporate any, new privacy protections, et cetera, that might be standard for the department. Yes, sir.
Can I, briefly, I made a mistake when,
Mhm.
the chair asked about the disclosability of the rebate summary data
Yeah,
via 91A. And I said that it's, that by that pathway is disclosable at the NDC level. That's not true. It says here, the commissioner may release it, but only at the aggregated level. So,
Okay.
so I apologize for that mistake. And that said, that places greater emphasis on maybe the need for an MOU that specifies that, but also specifies the level of confidentiality
Mhm.
there. So I just wanted to
Thank you.
make that clear.
Thank you for looking at that. I got it. Let's see, member recruitment. There are a few people that might be coming off the board, just due to term limits or shifting priorities. So Gary and I have met with a number of individuals, identified at least a few who we might be able to bring on the board, and really excited to announce those people once we get to that juncture. But we're actively looking for people to come on the board. I know it's a big time commitment and people are scared of prescription drug pricing, so it's hard to convince people to do this, but I think we have found some folks. In terms of external presentations, I have that on here. I met with a number of folks within the health policy sphere in New Hampshire for the past month or so. Lucy Hodder was so kind to talk to me for a while. I met with the great folks at the Fiscal Policy Institute, at Fournier, folks at Dartmouth, Carrie Cola, and Emma Dean at Dartmouth. And so we're plugging away at getting our name out there and hopefully getting some academics interested in working with us or helping us as we go forward. I also spoke at the CARSI Policy Hour. That's at the UNH, the University of New Hampshire. They had policy hours. I did the one in January, and Dr. Woodward was there. Listening, he was listening. And that was really great. I did not expect for so many questions, but people were really firing away. They kept me on my toes for 8 a.m. in the morning. But that was fun to do. And then I was recently invited to join the National Academy for State Health Policy. They have a coverage cost and value steering committee. They have an academy of state policy leaders. And so they invited me to join that. So I was nominated by somebody and so anyway, I will be participating. That won't take away too much of my time. But it gives me an opportunity to learn from still more states and to elevate the work of New Hampshire. So I'm excited to do that as well. I did just want to flag some environmental updates. There's a lot going on. A lot has happened since we all met in November, and I think it's probably good to keep up with what's happening at the federal level and kind of what is the latest research telling us. I think every year, there are two main times in which manufacturers increase their drug prices. It's January and in June, July. And as of January 2nd, there were 576 brand name drug price increases, which averaged around 4 to 5% of WAC increase. That was done, if you guys remember, Antonio Chiacha, who spoke last year, his firm 46 Brooklyn, they do this wonderful analysis every year. And so you can look to that, or I can send that around. In terms of the IRA, what's going on with Medicare negotiation? Again, this will be the second year of Medicare negotiation, and those 15 drugs that are selected those will have maximum fair prices in 2027. Just to remind everybody that Medicare negotiation, that's a major policy initiative really aimed at reducing healthcare costs, and CMS released a list of 15 drugs based on overall gross spending and their market exclusivity timelines. I just want to set the context and overview for a reminder about healthcare costs. US healthcare, it remains really expensive, very high, nearing 17.4% of GDP. That came from the National Health Expenditures that is annually produced by CMS, that came out in December. Retail prescription drug spending, that saw significant growth post-pandemic, increased to 11.4% in 2023. And the key drivers are really high-cost meds, specifically for obesity and related conditions. Probably not a surprise to many. When it comes to the 15 selected drugs, just to drill down a little bit more, those drugs account for $256 billion in global revenues, with $177 billion derived from the US market. Those are just 15 drugs. The focus, again, was largely on small molecule drugs, which you'll probably see in Part D, which is largely retail prescription drug spending. As Medicare has the authority to look at Part B spending starting in 2028, we may see more larger molecules that are swept in. Looking at the therapeutic focus, many were chronic conditions with large patient populations, like type 2 diabetes and cardiovascular risk reduction. We saw the semaglutide portfolio was brought into this round. And some notable drugs, just to kind of highlight kind of what the policy framework is and how that do what?
That's Uncord.
Is that earthquake?
Yeah.
Really?
Yeah.
Interesting.
Double check.
Oh my God. I know, it hurt how much it was spending. It was like, no. hold on.
That's an omen.
I know, right?
Unless it was the DA kicked us wood.
Okay.
I guess 3 or
That was
4,
an-
maybe.
No, I don't.
Let's see what Twitter's.
Yeah.
I feel like we should be getting an alert, right?
Yeah, we should.
Right? We should get an alert if that was something.
Still.
Yeah, that was kind
That
of.
whole building should.
It
Yeah.
wasn't just DH, it just someone on the meeting at home texted me that they felt it, and the other side of Concord.
Okay.
Oh,
Yeah.
wow.
Yeah, my mom just texted me and said she felt an earthquake in Barnstead.
Okay.
Oh,
I guess it was.
And Boston.
And
Boston.
Okay, now we're getting bigger.
Yeah, yes, right.
Wow.
Be interesting. So see, that might, if.
That was weird.
That was, yeah.
Where it was. I've been in the
I've only
7.5.
felt one.
And Vermont.
And
And
Vermont.
Vermont? Wow,
Yeah,
7.5.
That's 7.5.
Did it say what magnitude
shaking.
it was?
Yeah, 14-story building across the street from me came down pancake.
Really?
Yeah.
She didn't feel anything.
Oh, no, he just, they
No.
felt it in Vermont, down in Boston.
Yeah.
Right.
Yeah.
Well, this historic moment we all share together. Okay, I'm just gonna highlight a few notable drugs that were selected this year. One is Austedo. That drug, it does have an orphan indication. Interestingly, there's a generic that has been around for many years. It is available abroad. It is not available in the United States. So other countries do not cover Austedo. It's the brand name version of a generic that's already on the market. So they are largely dependent on US revenue for that reason.
What's the generic?
I don't know the generic's name. I don't know.
What does it do?
I don't remember what Austedo does, but I can get that for you. The entire semaglutide portfolio was brought in. Again, just to remind everybody, CMS defines well, the IRA defines the drug, but they define it by the active ingredient, not just the name of the drug. So Wegovy, Rybelsus, and Ozempic all share the same active ingredient, which is semaglutide. Because Ozempic was approved, the earliest, it caused all of them to be brought in, which is good for spending, maybe not great for all of the manufacturers, but it's good for it's good for Medicare. And they all qualify again because they share the same active ingredient. And there are significant implications if Medicare does choose to expand coverage to obesity treatments, which it does not currently do, but it could, and that was proposed by the Biden administration. We'll see how the Trump administration goes forward with that. Certainly at a lower cost, it could be more favorable to increasing utilization. And so Ozempic and Wegovy were both on our high cost drug list, so it will be interesting to see what the maximum fair price is with implications for whether we determine to reference price or something else. The other two are Linzess and Xifaxan. They treat many different conditions. They both treat IBS. They both have generics and over-the-counter drugs available in other countries. And so this will be very interesting to watch to see if CMS prices in those generic prices from international markets or not, and how they arrive at their initial and final offer. Xifaxan, it does have a rare disease indication and it is used as an antibiotic, and those have different incentives for drug development. But it is interesting to see that there are generics available, just not in the United States for some of these drugs. And I think it also does call into question how we are incentivizing innovation and what are we paying for. So I think those are just some early insights that I wanted to share. Again, this is the second year, so there's still more to be learned, but I think those are just some notable call outs. In terms of the policy implications, we may see, and I think experts are watching how manufacturers shift their R&D strategies. Previously, we talked about evergreening. We talked about in the report. Those are small tweaks to a drug to kind of extend its exclusivity. The way in which the IRA works is that those are unlikely to be revenue generators going forward. What we saw are that combination therapies that might be used more extensively by manufacturers. Janumet was on the list of drugs for 2027. Januvia, if you recall, was negotiated for 2026. They share the same active ingredient, except that Janumet is combined with metformin. So you could take Januvia and metformin, but this Janumet is a combination therapy, which allowed them to kind of escape the first round of negotiation and extend it by a year. So it'll be interesting to see whether we see an increase in combination therapies. Again, negotiation efficacy. So 4 of these 5 drugs could face generic competition in 2027. Once they face generic competition, they don't have a maximum fair price that is applied to them. So it'll be interesting to see whether or not we see accelerated entry of those generics, if manufacturers allow them on the market, or if they come on the market before 2027 or not. And then, you know, the criteria for selecting these drugs are very late in the drug's life cycle. So that also calls into question if this is, you know, the best bang for your buck by negotiating very late in the life cycle of a drug, or more towards those initial years under its patent protection. And then some other things to watch. I think it'll be notable to see how the Trump administration might approach negotiation, whether they drive for, you know, deeper discounts or, you know, make more to do about international reference pricing. And some have posited that the list of 15 drugs could change by February 1st. I think that is unlikely to happen, but it'll be interesting to see, and I'll certainly be watching that list. We may see, we also should, you know, watch how plan formularies may react to this. CMS is actively watching that. But how do plans that serve Medicare beneficiaries, how do they make those drugs more readily available at those negotiated prices, or do they leverage other drugs that may offer deeper discounts in the same therapeutic class? So those are just some things to watch, I think, and at the federal level, just a backdrop to be mindful of. There was a flurry of activity last week with the new president coming into office. And I just want to turn attention just to one executive order, which was called the Lowering Prescription Drug Costs for Americans. That was rescinded by Trump last week. But I just do want to clarify that all that EO did, all that executive order did was to task the CMMI, which is the Medicare and Medicaid Innovation Center, with developing new models of testing payment alternatives for prescription drugs. There was a Medicaid cell and gene therapy model that was launched. There was another model looking at Part B payments for accelerated approval drugs. Those are drugs that come onto market earlier in clinical development and promise to confirm their evidence at a later point in time. And they were also testing a $2 generic copay formulary. And so it's unclear whether or not those models will go forward. CMS is much further along with the cell and gene therapy access model than they are with the other two models. But it's not at all clear whether those demonstrations will fall or not. But it will be interesting to watch. But I do want to clarify that nothing that he did revoked or rescinded the IRA. It didn't increase insulin prices. There was a lot going around on social media saying that he did not increase insulin prices. But what he did do is rescind this executive order. The report did come out and those models are already underway. It'll just be interesting to see if those continue to go forward or not. And then the last thing I want to call attention to is under the Consolidated Appropriations Act, which is where we get the No Surprise Billing Act, which I think many of you are familiar with, and certainly the Insurance Department. Insurers and PBMs, they need to submit rebate data to HHS. I believe it was made reference to in the redundancy report. There was the initial findings came out, published by RAND, and they looked at 2020 and 2021 submission data. I'm just going to highlight some of the things in which they found, which may be helpful, especially as you all are looking into the collection of rebate data. They noted that formularies are becoming deeper. That is, they have more tiers to differentiate drugs at different levels of cost sharing. Deductibles, they increased on average by 5% annually between 2014 and 2022 among employer plans, and then 8% annually in the individual market. The authors found ratios of net to gross drug prices of roughly 0.8. So that means for every $100 spend, plan sponsors later receive $20 back on average. And then all data submitters used inconsistent and varying approaches to aggregate and attach identifiers. It made it incredibly challenging, if not impossible, for these researchers to calculate the net effects of rebates on premiums or cost sharing and the generosity of coverage. And I think one thing that's complicated in all of this is premiums are used to attract customers. And so when you think about how there may not be a one-to-one relationship in increasing in drug prices, that may explode premiums because you can shift things over on the medical benefit, and likewise you can shift things over to the pharmacy side. And so I think they weren't able to tease out the direct effect of increasing spending, and it was very challenging to even make sense of how PBMs report it or how insurers report it and how to marry or to crosswalk all of that. So I think it was a good report in that it gave us some insights into kind of what are the rebates levels in aggregate in the commercial market. There wasn't anything very specific at a state level or by therapeutic class or by drug. But it does offer some new points of entry for examining drug spending. And these are biennial reports. So the next one will come out. This was released in 24. The next one will come out in 2026 and so on and so forth.
So the agency report that you're drawing.
Yeah, so that's from ASPE,
Okay,
ASPE, and it was actually done by RAND.
okay, and
Mhm.
entitled or?
I can send it to you.
Send the URL or the.
Yeah. I'll send and I can circulate the report as well.
I worked for ASPE a long time ago,
And did you?
Yeah.
Interesting.
long time ago.
I'm sure it wasn't that long.
Yes.
Okay, that's it for my updates. We can turn to our presenter unless there are any questions there. Yes.
Not so much a question on this. First of all, thank you for that. It's very insightful to have the background information. A couple of things before we get into the presentation, if I will. I did send out a link to a survey. Kurt's evaluation's coming up. He's done. I just want to be sure we give him as much feedback as from a board member's point of view. Nothing will be shared individually. It'll all be shared in the aggregate. I just wanted to have the ability to let him know from us collectively how he's doing, both for professional as well as personal growth. What he can improve on and so forth. So if you haven't seen the survey, haven't done it, so forth, I do ask you to complete it. The May meeting is going to be on Memorial Day, which will probably be low attendance. So my recommendation is we could either move it a week forward. The month of June actually has 5 Mondays into it. So we can move it into the following week, which would be June 2nd, and move the one from the 4th Monday of June to the 5th Monday of June, which would be June 30th. Do people have a preference which way to go?
No, but I had mentioned to Kirk before we started that the February meeting occurs during Senate break week. And I think
Oh.
most of the House committees will be on break as well.
Then probably.
So, but there's somebody
Register.
scheduled,
Essex County, so, yeah. Yeah, I look down.
so that one's nailed down.
So on the one for May, week early, week late, to move the one in June from the 4th to the 5th. Any preference here? No. No,
Maybe the week, yeah, maybe the week before Memorial Day.
but that will be 3 weeks between,
Oh,
so
okay.
that's the only thing I have a concern on versus, which is fine, then we have a long break between that one until June, which would be like 6 weeks. So I'm trying to,
I see what you're saying.
I think going to June 2nd and then doing it again on June 30th would be more logical, because it'd be towards the end of the month, and break gives more time between meetings to get some things done. So that's kind of where I'm leaning towards.
We'll be out of session by June 30th.
It's on the budget.
Okay, so we'll have Cindy present the budget.
You can present the budget.
Burned out.
We're moving the May 26th to June 7th.
I think June 2nd, and also make the last meeting June 30th. We don't meet in July, which allows for the legislative body after the budget cycle to recuperate.
To take-
We all okay with June 2nd and June 30th? Yeah. Okay.
Great. Okay, and Trevor, are you able to get on your mic? I just want to.
I think I am. Can you hear me fine?
Right. Hear you fine. So, I'm very excited to have Trevor Douglas here to speak to you all. I met Trevor very early in my career, so it's been wonderful to work with him and grow alongside him. Trevor Douglas, he is the director of the Oregon Prescription Drug Program, also the director of the Pharmacy Policy and Programs in the Oregon Health Authority. He helps to administer ArrayRx. It used to be known as the Northwest Prescription Drug Consortium, which is a partnership between Oregon and Washington, and Trevor will go into that. They are now known as ArrayRx, and what we have brought him in today, one of the goals that you will identify for this year is to explore a discount card program that could be offered in New Hampshire. And ArrayRx offers a discount card program that has some advantages to those that are already, kind of on the market with GoodRx and Optum. So I will turn it over to Trevor to take it away.
Your large screen.
Thanks, Kirk. Appreciate everybody's time this morning. I hope today I can leave you with a really broader understanding of how Oregon and Washington, as Kirk has already pointed out, have forged a multi-state pharmacy solutions consortium over the last 2 decades. And I hope also to answer your questions. So in an effort to keep pace with the board's questions, please do interrupt me. I will do my best to pick up where we left off, and just extend me a bit of grace if I need to stumble a little bit to restart after your questions. With that, go ahead.
Thank you for this. I just want to be clear that there has been no compensation for ArrayRx, no obligations that the board is committed to ArrayRx. This is strictly voluntary, that there's no hidden agenda here, if you will, as far as any kind of relationship between the board and the Array RX?
So I can assure you, as a state employee, I have taken no compensation other than the compensation that I received from the state of Oregon. And I am not receiving any money at all from anybody other than my employer. And I think it'll become very evident to you what ArrayRx is or who ArrayRx is as we proceed through the presentation. I want to thank you for the question. And with that, is there any other questions before we kind of launch in here?
Thank you.
All right. So with that, I wanted to make sure that we had a really kind of good roadmap as to where I wanted to take you this morning. So as we've already heard, I want to talk a little bit about the origins of the consortium, how the consortium is governed. Then I'll dive a little bit into the discount card program that we have. I'll talk a little bit about the other programs that ArrayRx administers. And then I'll spend a little bit of time talking about our focus on ensuring independent pharmacies and our programs that are designed to curtail the growth of pharmacy deserts. We call that our critical access pharmacy program. And then I'll talk a little bit about what makes us different from other pharmacy benefit managers. I wanted to make sure that everyone kind of understood what PBMs do. So these slides are more informational. I'm not going to spend a whole lot of time on them, but I think it's important to just note that, state programs, public sector programs that operate pharmacy benefit plans, all in some way, shape, or form need some of these services, if not all of these services that PBMs offer to manage their formularies, process claims, etc. All of those things are here. One of the things I wanted to help organize for our audience and just generally, because I often find this as a question, is how PBM models or how contracting models differ across the environment. So if you look on the left-hand side of this slide, you'll see essentially three buckets or three models that are utilized. And then in the grid, you'll see text that is white and you'll see text that is black. And the idea behind this matrix is to help everybody understand what favors the payer. So black text, generally speaking, is better for the payer. And obviously, the opposite is true in terms of the lighter colored text. And each of these. Yes.
Quick question. The looking at your this slide and the next slide, it seems to me that one of the issues that's become prevalent is the ownership. That PBMs are no longer standalone organizations. They are often owned by and have become essentially for-profit operations. Some of the way you divided this up doesn't make that clear. What would you think about adding I don't know how you'd color it differently, but adding which are traditional, of the traditional models, what percentage are now for profit, what are not for profit, and the hybrid, what are profit versus non, what about the pass through, and what's the ownership?
Ownership. I think the critical one, yes, ownership is an important factor.
Thank you for the question. So I'm speaking specifically about the different types of contracts. You're absolutely correct. Vertical integration exists. The ownership of these PBMs does matter. And I totally applaud you for recognizing that. What I'm trying to illustrate here is that there are different contracting models that have historically been and currently being utilized in this space. And some of the large vertically integrated PBMs might have spread or traditional modeled contracts. They might also have hybrid contracts, and they might have pass-through contracts. So
But it
the
would be-
intent. Go ahead.
Yeah, it would be interesting to know what the proportion of the traditional that were for profit, proportion of the hybrid that were for profit, proportion of the pass-through that were for or not for profit.
Yes, that would be interesting. All right, so question taken. I will do my best to see if I can't get something back to Kirk at a future date. All right, so essentially, I hope this slide, again, I'm not going to spend a whole bunch of time on these introductory slides. They're just more informational and trying to level set as to how PBM models, contract models work, and for your reference later. The next one is just focused on how money is made. And in these spread-based contracts, obviously, spread capture, for those that aren't familiar with what spread is, essentially the PBM acts as a middleman, carves off spread from the pharmacy transaction, or retains portions of the revenues collected under a rebate agreement. And those are the revenues that the PBM operates off of and profits from. All the way to the direct contrast of that, the pass-through model is where there's really 100% pass-through of the price at the pharmacy counter, as well as all of the rebates and funds attributable to any of the claims that the payer pays on the rebate side. Those two models can be kind of morphed together, and elements of each of those contract types can be morphed into that second column. And you could have a myriad of different permutations in that hybrid model. As you can tell, this can become very confusing, but we really believe at ArareX that the pass-through model is the most predictable, allows us to have the insight that we need as public sector folks operating programs that are funded by the taxpayer. So, who is ArareX? Another question?
We go back, yes. Go back to the previous slide, please.
Sure.
So simplistically, the way I'm looking at this, as we go from the left to the right,
Yes.
it appears to be that there's more administrative than the bottom there, administrative burden and negotiating skills that are necessary to get to that bucket. You're relying more on, if you will, on internal staff, their knowledge base and so forth to become good negotiators, understand what's going on in the administrative part of it. And for the left-hand side, and the reason I'm bringing this up is that I was in a position before working with some people in the HR department.
Yep.
And one of the things I recognized right on was many people in the HR department don't have time for the administrative burden, and they don't have the knowledge base to be good negotiators. So is that kind of a fair way of looking at it and saying it's really moving the task of understanding certain things from the PBM back to the internal staff, which may not be there?
That's a very good question. I'm going to try to illuminate why we think we can fill that void at ArareX. And I think it'll become evident with this next slide. But your question is very, very good, because we often see administrative plans that rely heavily on outside consulting firms that may or may not be conflicted in their directives and advice. And then also we see plans that are doing their best, but don't have the clinical bandwidth, perhaps, to understand how the formulary is being administered from a safety and efficacy standpoint, first and foremost, and then a cost as a secondary data point. So all of those things that go into managing a pharmacy benefit have multiple aspects to understand, and you need to rely on people that you can trust to advise you and prepare you for the negotiations and also the overall administration of your benefit. So let me talk a little bit about what makes ArrayRx unique in that vein, and then if you have further follow-up, I'm happy to take that. So who is ArrayRx? This is a question we often get because people want to understand who makes up ArrayRx. Firstly, ArrayRx is not a legal entity per se. It's a doing business as name essentially for the work that Washington and Oregon have stood up, and exists inside of what's called a cooperative procurement group that allows any public sector entity to participate via an intergovernmental agreement. It's comprised the overall administration of that cooperative consortium is comprised of public servants from the participating states, and I'll talk a little bit about who all of those folks are in a little bit. But as you can imagine, all of our efforts to impose, a pass-through arrangement and hold our administrators, the contractors, accountable, faces a myriad of different pressures, all the way up to the political capital and the lobby that is poised to curtail all of those efforts. And it's because of the fellow public servants that sit with me on the steering committee that we really feel we're in a really great position to assist those states and other public entities with that knowledge base that you're pointing to that some programs may lack. And I think you'll become very, very impressed with who these folks are and the experience that they bring. The other thing that I think it separates ArrayRx from any other type of pharmacy benefit management solution is that all of these folks that work with me have an aligned fiduciary responsibility. We all have public programs that we're charged with being stewards of. And no other entity in the country has that alignment as it relates to the fiduciary responsibility. And also mentioned that there's no other PBM that I'm aware of in the country that has two departments of justice from two different states review their contracts. That's just unprecedented, and I haven't found another program that can say that. So I think just before I go any further, I think it's important to have like a guiding light, and the whole of the steering committee really felt it was important to really understand where we wanted to head as a consortium. And so that led us to the development of our mission statement. I'm not going to sit here and read this, but clearly it conveys our unique position, and no one can understand the nuanced public sector pharmacy programs better than those who actually operate and work inside of them. And as I said, no other private entity or company or consulting firm shares the fiduciary responsibilities and the stewardship of tax dollars. So it uniquely positions those serving on the steering committee. And let's talk a little bit, before we talk more about the steering committee, let's talk just a little bit about where we came from and how we got to where we are today. So back in 2003, both Oregon and Washington had initiatives, believe it or not, guess what? Pharmaceuticals were becoming unaffordable then. Um, Not much has changed. Continuing to see affordability be an issue even today. But the foundation of the consortium began actually as trying to find a solution for uninsured, underinsured, and seniors that needed help with the affordability of their medications. And this predated Medicare Part D, as you will note here based on the timeline. But very quickly, Oregon and Washington soon realized that they were charged with doing very similar things, and their enabling statutes were very much aligned. And so it became clear in 2005 that we could probably leverage the lives in Oregon and Washington together and mutually benefit each other by forming this consortium. So that's when the Northwest Prescription Drug Consortium was formed in 2006. As Kirk mentioned, this effort has largely been driven by Oregon and Washington. And over the course of the next few years following 2006, you can see there is a number of programs that were identified as other purchasers of pharmaceuticals. And we worked together within our respective states to deliver solutions to serve each one of those public sector entities and to effectively leverage their collective purchasing power to better position the purchasing power, not just of each individual state, but of both states collectively. In 2018, well, actually starting in about 2017, but for sure in 2018, we started to get a lot of interest from other states, understanding what Oregon and Washington have been doing, and we began to share our successes and multiple different innovative programs that we started to create that were born out of the need of the public sector to find a trusted pharmacy benefit solution provider. So we realized that during the next procurement cycle, we needed to expand outside of the state borders of Oregon and Washington and make sure that the next generation of contracting really expanded our reach across the entire country, whether you're a state, a territory, or in the District of Columbia. So in 2019, we issued an RFP that allowed for, or that required that the bidders be able to provide the services that we stated and I'll describe later to the entire country. And then in 2022, when that new contract took effect, we quickly saw the addition of Nevada. Following that in 23, Connecticut, and this last year, the state of Ohio. So I think from here, let's go loop back to talk a little bit about the steering committee, who comprises the steering committee, how the steering committee grows over time, and what benefit that brings to states that participate. But before I go into that, I'm hearing a little bit of noise, so I'm going to pause for questions. Hearing none, proceeding. So the originating states set up a steering committee that included key folks from across the public sector in their respective states. Each state, Oregon and Washington, had 4 members. That has been retained as it relates to the governance of the steering committee. But as each new state comes on board and that executes a participating program agreement as well as an intergovernmental agreement, that state would have a full voting seat on the steering committee, and would be advisory to all of our governance and oversight of our contractors. Who are these folks? This is our group of professionals. This group, this group that's pictured here, we're missing one doctor of pharmacy from the state of Ohio. Ohio came on in October, and we still haven't had a chance to figure out how to add an odd number of pictures to our slide here, but we're working on that. This group of people represents over 180 years of aggregated experience. So that speaks to your question about, well, how does an entity that has now the burden of responsibility to understand all these administrative complexities and the clinical aspects, where do they turn to, and who can they talk to and rely on? You can see that over half of our committee are clinical folks. The other folks are either seasoned procurement professionals or have relevant health systems and analytical experience in the public sector. This spans public employee benefits programs, workers' compensation programs, Department of Corrections, Medicaid programs, and the latest member being Tracy from Ohio, who shares both time administering a Medicaid program as well as now moving into the workers' compensation program, and we're lucky to have her expertise on board as well. So these folks meet every week. We're not a stagnant group that meets just periodically. We actually have agendas that get populated out by the end of each week and sent out. We monitor all of our programs. We monitor the programs in every state, and we make sure that the contractors that we work with are executing the terms that we expect and the performance that we expect. So how do we do that? Well, we really have three pillars that we really want to make sure all of our programs that we offer are stood on. So we want to make sure that we, as a public sector entity, I think we all appreciate a fixed fee approach, where we know going into a coming year, we can predict, okay, this is what the fee is. This is what it means in terms of a budgeting ask. So we as public sector entities wanted that predictability going into every single year. And we wanted to make sure that the services were all inclusive as all inclusive as they can be, to ensure that there's no surprises later on. I hear another voice. Just want to make sure we're not missing anybody's question.
Nope, you're good.
Okay. We also wanted to make sure, and this is a highly overused term, transparency, but we really wanted to make sure that our partners respected our commitment to pass through. So we wanted to make sure that we had access to our data. It's not transparent unless you have full access to claim level detail data. So that's another thing that we require, along with comprehensive reporting, which I'll talk a little bit more about in a minute. And then we wanted to make sure that we had full auditability rights. We wanted to also make sure that there was ongoing review of our performance every single year. So we have a requirement that a third party market checks our performance, and that means performance of admin as well as drug costs, and compares them to comparable market comparators. And we have language in our contract that also states that if that third party market check demonstrates that there could have been a more advantageous solution in terms of cost savings within a very, very narrow margin, we have the right to renegotiate terms or require a change in how things are are administered for us to ensure that we remain market competitive. I think the next slide helps better organize how we oversee things. So I said already that there's no other pharmacy solutions provider that is overseen by two states' departments of justice. That's probably one of the main differences that I don't think anybody else can touch. But I wanted to just point out again that if you don't have access to your own data as a payer, and you can't ask for and receive claims level data, then sorry, your PBM relationship is not transparent. And our programs also are bolstered by a robust set of standardized reporting requirements, along with the ability to customize that reporting. Oftentimes in the reporting world, a standardized report offers a very limited snapshot into what your program is doing. Our tools are built on a Tableau platform, and we have a high degree of customizability so that we can actually manipulate our own data within that tool, and that it's easy enough for me to use. So it's super helpful, and it's real time, and we can if there's a question about something, we can go and drill down quite easily to what it is we're trying to focus on. I also wanted to point out, inside of that standardized reporting package, there's something called a basis of reimbursement report that goes to every participating entity. And that helps each entity in a snapshot very quickly assess how they're performing against our guarantees. And it also helps us compare the performance as a steering committee from one participating program to another, and to monitor overall compliance across our whole book of participating programs. And to mutually benefit from innovations that might be happening in one group and not in another, and test and allows us to then effectively test what best practices might be, and then leverage those across the entire book of business and participating programs. I think we also have reports on rebates. We also have what's called most favored nations reporting, all of which bolster that pillar of auditability and transparency, and the pillars of auditability and transparency that I touched on previous. So how does this all fit within the context of what it is that we offer? Well, I think it's first important to kind of get a good picture of what it is that we offer, and to also make sure that you understand that this is an a la carte set of services. A participating state does not have to do all of these things or elect to adopt a RareX broadly. In fact, our states are all at different parts of this array of services that you see on the screen now. So we have just over 20 participating programs now, and we span the gamut of the discount card, where we kind of originated out of, and then we have deepened our participation in the PBM service realm, serving various different groups, and recently just added Medicare Part D. So I can talk more about these specific programs if you wish, but I'll just really quickly touch on what each of the other programs are, just for your understanding. So the voucher program, those programs are essentially stood up to help facilities that serve people that are entering back into the community, or that are coming into a facility whereby the facility-based pharmacy might not have a medication, And instead of going to the pharmacy and paying the usual and customary, they can utilize a voucher program and secure the ArrayRx negotiated price at a community pharmacy to serve that patient until that facility pharmacy can get that product in the facility-based pharmacy. That happens in the corrections space, and it occasionally happens in the state hospital space. The other side of this is discharging folks from those settings. When someone's a justice-involved individual transitioning to the community, it's always nice to ensure that if they are stable on medications, that they stay stable by having access to those medications once they find their place in the community. Similarly, those leaving a psychiatric hospital, it's important for them to remain stable. So these voucher programs have helped recidivism and helped ensure that folks stay on the regimen of medications that have proven to be successful for them when they're staying within those facilities that I described. The ASO rebate services. ASO stands for Administrative Services Only. So often, well, not often, but sometimes programs that have an ability to pay claims haven't really had an ability to collect rebate. And so Washington State's Labor and Industry, or the Workers' Compensation Agency there, is a good example of this, where they had the ability to pay claims, but they had no ability to collect rebate on that utilization. So they were able to contract with us and secure some rebates from their utilization, and as a result, lower their net expenditures for that agency. Similarly, Washington State also had a subscription model for hepatitis C with a competitive procurement that allowed for the entire state to benefit from a rebate that needed to be administered. So we stepped in and helped them administer that subscription model and invoiced that manufacturer for the necessary rebates pertinent to Washington's agreement. So highly customizable. We also have other administrative services only contracts to provide clinical services to Medicaid programs. And so one of the contracts that we have right now is actually supporting Washington State's Pharmacy and Therapeutics Committee with a pass-through contract securing clinical services for the committee. One of the unique offerings that we've just developed is a Medicaid fee-for-service program. We took it upon ourselves with the expertise that we had on the steering committee, but also solicited the help of various Medicaid pharmacy administrators across the country to understand the pain points that they all had with their existing platforms to manage pharmacy benefits for the fee-for-service programs in their respective states, and redesigned and designed a robust set of services for the fee-for-service Medicaid space. And that product is ready to go now. So that gives you a little bit of idea of how many services that we offer, but it doesn't give you any idea of how we operate them. So I'm going to talk a little bit about our partners next and how we operate. And I'm just looking at time. I want to get to the discount card next after this. So we do have. Yep, go ahead.
So could you go back to the previous slide?
Yes.
One of the things that that's implicit in this slide is that the funding mechanism, which I don't see explained in any of the previous or coming slides, is program specific. So could you talk at some point on the different funding mechanisms? So for example, is it the state that buys into the program or funds the program, or is it a agency of the state, or is it an insurer, or is it an individual within a state? And if you could be specific about distinguishing between the funding for the PBM services, the discount, the vouchers, so go ahead.
Extremely good question. So yes, for PBM services, there is still a fixed fee that's associated with the administrative costs. And if a public employees benefit program wish to utilize ArrayRx, there's literally no cost to join the consortium. However, once there is a participating program agreement executed with our contractor, then that fixed fee that we oversee is what the public employee benefit program would pay on either a per paid claim basis or a PMPM, whichever makes the most fiscal sense for the program. And smaller groups might like that per paid claim basis. Larger groups may like that PMPM reimbursement basis, but it is fixed on both accounts and known to both payment methodologies that are going on. So that's how that array of services on the PBM sides or the PBM services side. The discount card program is funded on a transactional basis. So each paid claim that a card member pays at a pharmacy includes a small administrative fee that helps fund and operate and sustain operations of the discount card. So each individual pays a very small nominal amount when they're making that purchase at the pharmacy counter. Voucher programs also have a very nominal per paid claim charge that is paid by the entity that utilizes the voucher program. So for example, the state of Washington Corrections Department utilizes this voucher program, and each time they create a voucher and utilize that voucher, there is a small administrative fee that gets paid to support the operations of that program. Similarly, with the rebate services, there's specific charges that are known and upfront, and that are paid to compensate our contractor to perform those duties. Similarly, on the Medicaid side, the managed care entity that we have currently operating in Oregon that utilizes our services has a per paid claim arrangement with us, and that's how that program is sustained. There's a similar fee schedule for the fee for service Medicaid side of things as well. Does that answer your question?
Pretty close. Follow-up would be, do you have a return calculated on each of these we're
Absolutely.
representing?
Absolutely. So I can talk a little bit about that. So the PBM services, in terms of what we have seen historically, we've seen savings in the 20% realm. Discount cards, we see anywhere from 20% to 80%, depending on brand versus generic medications against usual and customary. And I'll talk more about the discount card specifically in a moment. Voucher programs, similar savings. However, I will just point to one county corrections department that we saved in their whole total spend in pharmacy, 51% savings in a single year, which is a huge savings for a local county corrections department that really has a limited budget and makes a huge difference when we're saving thousands of dollars in a space that they didn't expect to. Rebates, I think that's, sorry, go ahead.
Yeah, the statement I looked for is it cost them X and they got back Y in each year.
Yeah, so I can get into the specifics of that at a later time, but I would need to have some lead time to calculate all that out for you. Happy to get that back to you. Hopefully Kirk's keeping track of all the action items that you're generating for me.
I have a somewhat related question.
Yes.
So our state health plans, my assumption is that the insurer is making a lot of money on the pharmacy side. If we removed that from the contract and went with something like this, do you have any experience on what the effect on the rest of the cost to the state is for them losing something that's really profitable? Are they gonna bump it up?
That's a really good
Somewhere.
question. I often hear this same question asked different ways. And essentially, the mutualization that occurs when an insurer has control of both the medical side and the pharmacy side, and Kirk already touched on this this morning, is real. You know, if there is a loss on one side, we're going to try and take from the upside from another side to just try and, you know, offset those losses. Here's what I have said to other folks about this. I think it's important to know what we're spending, period. So if we have to separate the medical and the pharmacy sides of this equation, I think it's important because then the balloon squeeze can't happen, right? You know what you paid for the pharmacy at the pharmacy counter. You know what you paid for each claim. You know what you derived in rebate revenue from each one of those transactions. So you know what you're actually paying, right? The same can be done on the medical side, but that's not my area of expertise. But it allows us to have honest conversations about the reality of both of those environments and understand where some of those tensions are on the pricing and the cost growth in each of those different sectors of the overall health spend. So our experience has been such that once we actually have line of sight into what we're spending on the pharmacy side, we can really appreciate significant savings on the pharmacy side that you know then become very, very clear and help us in the entire equation as it relates to administering a health benefit to employees. Does that help answer your question?
Yeah.
Yeah, Trevor, one of the questions I'd like to ask about is, I've heard this before, is following up on Senator Rosenwell's question, is that when you start to do unbundle,
Yeah.
you know, part of it is, well, then you have this sort of unknown by people saying, well, your medical benefits are gonna go up more than you're gonna save on your pharmacy side. And that's one of the things I'm trying to figure out how we can get to that part of it, have that kind of a conversation. The other one too, I've heard from people is concerned about what I call financial responsibility or financial risk. Is that when you start looking at it, someone comes in and says, well, I'll take all that risk away from you. I'll charge you X number of dollars per patient per month. You haven't got to worry about it because that's a fixed amount of money. You can put in your budget. You can put that on the done list, if you will. But there's a hidden cost to that because you really don't understand, to your point, what you're negotiated away. You don't know what your true financial risk is. So the other question is, people have that experience or that concern, is there a way to get stop loss insurance to protect you from the financial downside that you don't understand where the tip of the iceberg is? You can see, but it's what's under the water that causes the problem because you don't have transparency to it. So first question is, when you start to unbundle things, how do we somehow address that issue? And the second one, what do you do about the fiscal or financial responsibility or risk?
Yeah. Lots on to address there. So I think that the first of all, it's the admin that is a PMPM. So it's just the admin cost. So instead of a per paid claim amount, you would spread the cost of the administration over the entire group as a PMPM, not the overall costs of each individual claim. However, we do have the ability to ascribe to a PMPM within our master agreement if a group wants to do that. But we also want to make sure that that makes fiscal sense. And so that's the other thing that we want to make sure that everyone has full visibility in. And so even if you're going to have us assume the risk and do a complete PMPM for everything, we want to share our data, the claims level data with you and help you understand where things are performing. And yes, obviously, we would need to make sure that we were appropriately covered for stop loss and those sorts of things in that environment. So hopefully that answers your question. I've lost track of what your other questions are.
Well, no, the other ones, when you start to unbundle things, I've heard it from a couple of times when I did that. We had some CFOs at different hospitals, and one of the things that they brought to my attention was in their conversation, well, if you take the pharmacy benefit away, you're gonna have an increase on your medical side because it's just, they're more synergy, what their argument was the synergy between the two of them by having them both with us versus if you unbundle it and all we have is the medical benefit and the pharmacy benefit goes away, we're gonna have to increase your medical benefit accordingly.
Yeah, well, I think another argument can be made as well. Like if you're leveraging both of those types of benefits to find the lowest net cost for the payer, I think that's really what we need to be examining and looking at. So a really good example is oftentimes the medical benefit does cover some practitioner administered medications, right? And that might not be the most cost effective path for that medication to be secured. And so it might make sense for the insurer to move that to the pharmacy side and pay for it at a lower cost through a pharmacy avenue, or for that matter, secure a specific program that effectively provides for what I affectionately call a site of care model that makes sure that all of these medications are being administered at the right place and at the right time for the people that we're serving. So yeah, unbundling from a pure dollars sense as it relates to one side or the other might create some sort of balloon squeeze, if you will, but it gives you a much clearer picture of what costs truly are. And like I said before, if you need to have difficult conversations about costs being higher on the medical side, you can have those conversations about what that means and translates to when you actually know where those tensions are and where those tensions are focused in, or what area in the medical side they're focused in. But when they're mutualized and put together, and you're trusting someone else with that fiduciary responsibility to manage this benefit, you're often blind to what the true costs are. So, yeah, I understand there might be arguments around, well, that might drive costs up, but I just, in our experience, we haven't seen that to be true when we've looked at the programs that we've worked in. So hopefully that helps answer your question or addresses your question. I want to get cranking here because we're running out of time, and I want to make sure that I get through this deck. Let's just really quickly cover this slide. And you can see that this is a pyramid that basically demonstrates the hierarchy, if you will. ArrayRx, the steering committee that you saw, they oversee the work of Moda Health. They are the successful bidder through a competitive procurement run through the state of Oregon. And they're a local insurer. However, they have a specific team that is focused on supporting the work that we do under the ArrayRx or the Oregon-based cooperative procurement group that is doing business as ArrayRx. They work to do all of those things listed in the magenta section of that triangle, and then subcontract with a PBM vendor, Navitus. They're out of Wisconsin. They are who provides our pharmacy network and the ability to adjudicate claims, and then also serve to help us with rebating with manufacturers. We also don't have an exclusive mail order vendor. We actually have two postal prescription services out of Ohio and Oregon, and then a Costco mail order. And we do have an exclusive specialty pharmacy. However, we utilize two specialty pharmacies The one we primarily use is Arden, which is located in Oregon, but operates in all states and districts and territories. And then we have another specialty pharmacy, Lumicera, that we use from time to time. Overall, of these services, we service over 780,000 lives across 5 states. I think the other thing that's important to note that all of our programs are highly customizable. We don't impose a monolithic solution on any program. We understand that when you see one Medicaid program, you've seen one Medicaid program. When you've seen one public employees benefit program, you've seen one public employees benefit program. Each state has unique challenges, unique statutory requirements, and unique program requirements. And we want to be responsive to each one of those things and work together so that we can mutually benefit from the purchasing power that we could collectively bring to the marketplace. Let's dive deeply into this discount card program. I think everybody is familiar with GoodRx, and I think it's important to recognize what our program is, and then I'll talk a little bit about how it works, and then talk about the differences. So our card, there's no age or income restrictions. There's no fee to join up. There's also no restrictions on the drugs that are covered. If it's an FDA-approved medication, it's eligible for a discount. All of the discounts are also extended to some non-prescription items. So over-the-counter medications, if you wanted to fill that over the counter at the pharmacy counter, oftentimes there can be significant savings to do that. We also cover diabetic testing supplies. We also cover vaccines. The other thing is this card has a national presence. So if you're a member in Oregon and you're on vacation in Florida and you get sick and you need medicine, you can go to a pharmacy in Florida and utilize your card. So it's very easy program to utilize, and I'll get more into how you enroll in a minute, but essentially you have 100% online enrollment. You get a digital card that goes to your smartphone, and you can use that within minutes of enrolling. There's online tools that help all of the residents of the participating states understand what the price is at each pharmacy that might be located nearest them, so they can shop online before they even go to the pharmacy and know what that price is. All they have to do to get that price is show that card that is on their phone, and then they pay that discounted price. I've actually saved more than 80%, but the law of averages lets me say that we save up to 80% on prescription drugs, more for generics, less for brands. Some of the things that we often get asked by customers and consumers, no, the discount card can't be used to pay copays, and oftentimes, unless there's laws in place, the discount card purchase can't apply to an insurance deductible. So how does this differ? I think I've already question.
Yeah, so if you could go back to the doesn't pay copays, the slide, the previous slide.
Yep.
There's small print in what you were just showing. I think it says this is not insurance. Right. So when it says that it doesn't pay copays, one of the issues, of course, is copay on what?
Yeah.
And if you've got you can't use the card unless you have some kind of insurance that provides prescription drug coverage, right?
No. The discount card is independent of insurance.
Okay, so if I then have a choice between using the card or buying through the insurance, right?
Correct.
So if I use the card, I'm going to do that on the presumption that the 80% deduction is cheaper than the insurance copay.
Yes. That
So
precisely.
you're not.
So one of the things that we get asked is, what happens if I use your card because my copay is $25, let's just say. For generics, it's $25, and for brand, it's $50. Well, I'm telling you now that there's plenty of generic prescriptions that are less than $25. And so the presumption is that a discount card person would want to use the discount card, right? And instead of paying that $25, because they're going to pay $17 for their prescription as opposed to the 25.
Thank you.
Thank you for the question. All right, so this slide is actually, again, I'm not going to go in to spend a whole bunch of time and crosswalk everything, but this lays out some competitors. But then it also in the bolded, bordered area talks about a Rare X discount card and what makes it different. Obviously, we're state sponsored, so that makes us hugely different. As I said before, overseen by two departments of justice in Oregon and Washington. And the other thing that I think is really critically important here is many of these other programs sell information of their users. So their personal information gets utilized, sold, packaged up, whatever. We do not allow that and treat each of those transactions as a very confidential health record. I also wanted to talk a little bit about reimbursement to pharmacies. I think that the other main takeaway here, based upon feedback from our community pharmacy partners in Oregon and Washington, where we have the most experience, is many pharmacies actually only now take our discount card and not many of these others, just because of how we pay and how we try and strive to keep reimbursement to pharmacies fair. And I'll talk more about that independent pharmacy and reimbursement element in a few slides, but I wanted to make sure that I just mentioned it here. Why sign up for the card? I think it's pretty obvious that prescription drugs continue to be a struggle to afford for a large part of the underinsured and uninsured population. I think there's still folks without Part D plans that can benefit from utilizing a product like this. There's also folks with high deductible health plans that can, benefit from utilizing the discount card when their deductible is not being met. They're in December and it's going to start in January. Am I going to pay the usual customary, or am I going to use my discount and get it for far less? And then some other things that I've already mentioned. One of the things that we've noted in Oregon and Washington recently is people in, there's been a lot of talk about Cascadia and those and a Cascadia event. You just had an earthquake. Well, that is something that people think about in the Northwest a lot. And so making sure that they have a month's supply of medication sometimes isn't easy to do with insurance, and they can utilize this program to secure themselves a 1 month lead on medication, so they have that medication. I was going to talk to you a little bit about how easy it is to enroll. Literally, it's 3 steps, literally 2 that you have to participate in, and the third is what's generated for you. But you can see here that there is very minimal demographic information collected from people. So first and last name, an email address, date of birth, a phone number is optional, and then a street address, and then a zip code. That determines whether a person is eligible or not based upon their residence. And then they are given this card that populates their screen that they can add to their Apple Wallet, take a picture of, store their photos, whatever way they want to save it. And they'll also get a follow-up email with the same information. But essentially, this is what displays on your phone for the pharmacy to utilize and process that discount card transaction. One of the questions we often get asked is, what does this mean in terms of savings and what is the average cost? So if on the left-hand side and the purple bars, that shows you the average price paid per prescription with the discount card across all states. And this is also an illustration of the type of reporting that you would have as a participating state if you chose to go with a Rare X. And you have on average between $30 and $36 per prescription. And then the overall savings ranges on the opposite side in the green line, anywhere from about $200 to $212, I guess, in savings per prescription. And of course, this is aggregated up across both brand and generic products. And just I wanted to illustrate this too. Here's Oregon's specific performance over the same time span. It kind of just shows you just a different perspective and aware.
Trevor, I want to go over the math, please.
Yeah.
If the on the average is roughly around $30, but the savings is $120. How do you have $195 worth of saving if the prescription only costs $30?
Yeah, no, most often, this is a good question. So remember, these are aggregated numbers. So across all brand and generic products, all it takes is a couple of different brand drugs that are purchased every month to skew the numbers to generate that much savings. So does that make sense from a mathematical standpoint?
Is the savings per prescription or per prescription over the course of a year?
This is broken down by month, as you can see, but it's the average price paid. So if you take the generics, which could literally cost you as little as $5 or $6 for the whole prescription, versus the brand that might be literally thousands of dollars, maybe $2,000 or $3,000, then the average gets skewed, right? If you have a lot of small dollar transactions, right? And if even just a few large dollar transactions, that can skew the average up, correct?
I'm with you. Yes, thank you.
Yep. Yeah. All right.
Another quick question, on the previous slide. If I were to log on and try and roll now, I would presume I would not be eligible. But if I'm only giving you my zip code, how do you know that I'm not eligible?
Yeah, so we base it off of the person who applies. We look to the zip code and address to verify that they are indeed in an eligible geography. And the other thing I will just point out is that this program is designed to serve whomever is living in that respective geography. There's no restrictions or other thing that we look at. So if someone's a student, for example, a foreign exchange student wants to take advantage of this and happens to be at the University of Oregon, they can enroll and benefit from access to this program.
So something at the New Hampshire level has to have participated. It'd be paying a fee, right?
Correct. Well, the fee is paid on every transaction. There's a nominal amount that is paid with the payment to the pharmacy to cover the administrative costs of running the program.
Who's paying the fee, Trevor?
The consumer.
The consumer pays, okay.
Yeah.
So the other question is, New Hampshire, unlike Oregon and Washington, which have some big states out there geographically, are relatively small geographic, are reported with, Maine, New Hampshire, Maine, Mass, and Vermont. And many of our employees, particularly state employees, reside in those other states.
Yeah.
So how would they benefit from this program if they're not living in New Hampshire, residing in New Hampshire?
They couldn't if we're talking about based upon where they reside or live.
Could they use a work address?
I'm not going to suggest that they can't. How's that?
Okay,
I'm just
trying to be sure we're trying to build a state program that would not somehow taken any of our potential state employees that don't reside in New Hampshire out of the equation.
Totally understand the question. All right, let's talk really quickly about other reports that you get. You get enrollment reporting, so it monitors how many people are enrolled and enrolling. So month over month, you get a report out of what that looks like. We also have de-identified utilization reporting. As I said, each one of these transactions is treated as a confidential health record. We do not get, and the contractor does not share with us details as to who's getting what. They just give us a reporting about here are the drugs that were provided by the discount card program to eligible members utilizing the program. And that gives you an idea of what types of medications are being the focus of people using programs such as this. Really quickly, let's talk a little bit about critical access pharmacies. And we know pharmacies deserts are growing across the country. And independents are disproportionately being impacted. However, chain pharmacies are also closing their doors. And Oregon is probably a state that is unfortunately very too familiar with this phenomena. We rank second to last in pharmacy access by a recent report from the Associated Press. And so we had to take action, and we had to change how we looked at critical access pharmacies. And historically, we recognize that pharmacies are an incredibly important part of our delivery system. We know that over half of adult vaccines are administered at pharmacy sites in our state and across the nation. And we also know that when pharmacists practice at the top of their license, they actually provide valuable clinical services and an ROI that is sometimes as high as 14 to 1. So we also acknowledge that pharmacy closures disproportionately impact high poverty census tracts as well as communities of color. And this is true for both urban and rural settings. So in addition to our different pharmacy reimbursement strategy that focuses on being fair to all pharmacies, we have an added program that identifies key pharmacies deemed critical access across the entire landscape of each individual state. This is operational at the state's election. They don't have to do this, but we have in Oregon for obvious reasons. And essentially what this does is it affords those pharmacies designated as CAP pharmacies, and some of those things are listed here on this slide, that they have to promise to do, or that they serve specific populations. It offers them access to a higher reimbursement, either on an ingredient or on a dispense fee. And we have seen, and we have also heard from these pharmacies that this really is a difference maker, and it really helps them stay afloat, which then curtails the growth of those pharmacy deserts that I spoke about earlier. That's all I'll say about that. I think we're running really short on time, if I'm not mistaken. Kirk, how are we doing?
I think we're doing okay. Yeah.
Okay. All right. The other thing that we also like to talk about and share with folks is, it's one thing to be able to say all of these things, but it's another to have it verified, right? And so we understood that there was an important part to verifying. And someone at the beginning of this presentation asked about, if there's any conflicts of interest or whatnot. We recognize that if we paid a third-party vendor to validate our contract, that's kind of obvious conflict, right? Like, we're going to pay you some money to tell people what we want you to hear. Fortunately for us, there was some funding available and offered to ArrayRx to have an independent review of our agreement. And Arnold Ventures backed that and paid the consultant directly to essentially evaluate our participating program agreement. And there's a quote directly out of that report. The entire report is available online. Encourage you all to go out and read it. But the takeaway is overall, ArrayRx is the contracts that we hold are more favorable to the client than the PBM, which is, obviously not the case in the marketplace as it exists today. And it further validates what our mission is, right? We are focused on that mission of delivering to the public sector and leverage the expertise that we have as public stewards in programs that run pharmacy benefit pharmacy benefit programs for whether it's a public employee or another group that's served by a public agency. Who can participate? I think it's pretty clear. I've said it enough already, but any local government, local organized group that is publicly funded is eligible. Inside of the state of Oregon and Washington, we have some unique statutory provisions that allows for private entities to participate. So we do have some private entities interested in participating with us because obviously if they can get the same rates as about 800,000 lives, they're interested when they only have a few thousand. Differences between ArrayRx and others, I think it's pretty clear. The next two slides kind of cover the gamut of the differences as to what separates ArrayRx from other PBMs. But the big takeaways here are the following. You have, upon participation with ArrayRx, you have access to a group of people that bring with them over 180 years of experience in this space. If you need to ask a question, it's quite likely that they're going to be able to provide you an answer in real time or be able to find the answer for you in a very short period of time. We also bring with us the aligned fiduciary responsibility that you're going to find nowhere else in the country, along with the Department of Justice and the Assistant Attorney General's review of each one of our master agreements and the participating program templates that are utilized across ArrayRx. Nowhere else will that occur that I have found. We also have an annual contract restatement that allows us the flexibility to keep nimble and responsive to market changes. We don't wait for 3 years, 4 years, 5 years to change the contract if we need to change it now. And I think the overall underscoring importance to recognize and benefit of ArrayRx is the effective leveraging of our purchasing power across not just your state, but collectively with all the states that elect to participate inside of ArrayRx. I will just finish by saying, here are the steps to join. It's not arduous and tenuous. Essentially, what happens is an intergovernmental agreement is executed between New Hampshire and the state of Oregon and the other state entities that are participating. Once the IGA is signed, it allows for a lead agency in New Hampshire to work with our contracted administrator, Moda Health, to execute a participating program agreement that pertains to the services that you wish to participate in and the program that you wish to operate. Again, it doesn't require that you execute all of the programs that ArrayRx offers. It's an a la carte choice. You get to choose which of those programs you want to utilize. And then that contract gets signed, the PPA gets executed. It's still overseen by the steering committee, has to be signed off by one of the co-administrators of ArrayRx, of which I am one. And there's then a timeline built and a project plan created for the effective implementation of the program you select. And then you go live by that date and start saving New Hampshire money. So hopefully this was a helpful presentation. Hopefully I paused enough for questions, but I remain at your disposal for as long as Kirk will have me to answer any additional questions.
Thank you, Trevor.
So Trevor, thank you. This has been very, for myself, informative, most useful information. I want to be clear though, at this juncture, what we're looking for, I think, is putting a toe in the water with ArrayRx, possibly looking at the discount card and hopefully building a relationship. If we decide to go down that path with ArrayRx to consider maybe other things, like you said, a la carte, is to, at that point in time, this is a simple way to, again, simply low risk, no risk, if you will, to state of New Hampshire at this point in time, but it would be beneficial to the residents of New Hampshire collectively. Then based upon that and how it may go, we could eventually expand if the state wanted to do something like that going forward. Is that a fair way to say it?
I think that's exactly how I interpreted it, and I think other states have the same view you do.
Any other questions on the discount card itself? We're not making any decisions today, so we'll make sure everybody is
Well,
up
one
to
of
speed
the
on what it is.
question, but one of the things I'd like to get from the board was the three of us here. But I think for Kurt is if there's any kind of support by the board to explore the discount card with ArrayRx. If there is, then let's take a vote to proceed accordingly. At that point in time, allow him to pursue that conversation with ArrayRx. If there's not support by the board, then at that point in time, I think it'd be fruitless for us to ask him to continue down the journey. You have questions about, or Jason? Go
I mean, not a question, a comment. I mean, I'm very interested. I mean, great support. I think given, our missive to make recommendations.
Yeah.
I heard the chair's comment about eligibility and outside, non-residents of the state not being eligible. So at first, my first deepest interest was this card for the state employees insured and the university system of New Hampshire, all the public payer. But I think there's a little bit of a gap there. So I'd like to explore that more. What is the eligibility requirement? Is it residency and wholly residency based, or is it the fact, state employee based? It would be a shame to not, let all of the state employees benefit from those discounts based on that narrow gap. So that's the first question, but I think it's really interesting. I think too, how might that come across to the Department of Administrative Services and who administers the benefit? They would want to probably do some intrinsic cost efficacy analysis to see if in fact it does indeed, the economics do indeed work. Because it's as Trevor said, this is not insurance. It actually works independently of insurance. And so they have institutional knowledge about the cost there. And there's a current bill right now, the copay accumulator bill, that kind of addresses this, whereas, Trevor had mentioned that this doesn't defray the endogenous copay or deductible coinsurance burden. Might that though, the accessing of an entire population, accessing these cards, have an effect on, the cost sharing revenues generated as part of the administration of the employee's health plan? I think they would probably be interested in getting some point estimates on that question.
No, really good set of questions. I'd be interested to find out what happens today with GoodRx. Because if those questions would be germane to whatever discount cards on there. So we should have a broad discussion about discount cards in general. I think sit down with Commissioner Arlinghouse, somebody else to talk about, how does that impact whatever you're doing? So I think if you limit just the one discount card when there's multiple in the market, is that at that point in time, how do we look at it collectively, not look at it individually?
Yeah, and using the existing ones as a
Yeah.
proxy is an excellent example, noting that, in this case, the state employees, they're ERISA plans. And so they're, as a fiduciary, kind of managing that and make decisions based on plan design that prospectively help them meet that fiduciary responsibility to the state insured plans. But that's a decision for them. I think this is great. I know so much more now after listening to Trevor's presentation. And so thank you for bringing that here. And it, 126 BB5 says clearly there in section F, section 2, subpart F, that exploring a drug purchasing consortia of sorts, to working as a consortium with other states to do these types of things is part of our missive. So I think my interest grows just after reading that and hearing all this great opportunities. Good work.
And I see, Trevor, you have your hand raised. You might could respond to some.
I would like to respond, but do you want me to do that now?
Yeah, go ahead.
Okay, so I wanted to just be very, very clear about eligibility. And I think it's important to note that we give a high degree of flexibility to our partner states to innovate and define what eligibility looks like in your specific region and what makes sense to serve your residents. So I think there is a healthy openness and a readiness to work with your state and other states that happen to be geographically adjacent to other geographies. To work on a solution that effectively addresses the eligibility concern. And I would just say the difference between other discount cards and a Rare X is if there is a power in the purchasing, the ability to leverage our purchasing power, it is in allowing all states that are eligible to actually participate within one vehicle that then makes our collective voices more relevant in the marketplace. And so that's the only other thing I would say. And then I'll stay on the line, but I just wanted to thank all of you for paying attention, not falling asleep. And then I wanted to just extend an offer to you all. Kirk has my contact information. If individually you wish to have a conversation with me or any of the steering committee, we wanted to make sure that that offer was extended to all board members today. So with that, I'll stop talking. Thanks.
Thank you, Trevor.
Yeah, thank you very much, Trevor. It's very informative indeed. I don't know Mark Cuban's discount card's name. Was that one of the columns that's on your table?
That's a good question. Cost Plus is Mark Cuban Cost Plus drug is his program. It's not a discount card per se. It's actually a program that has been made or been popularized by Mark. It's not something that's a new construct or new concept, however, because there are retail pharmacies that have been doing this strategy for years before Mark popularized it and utilized his position to bring it into the public's awareness and sphere. So hopefully that's helpful. But we are looking at that, by the way, as something to, again, with the steering committee, we want to remain nimble and flexible and work with whomever that is making a difference to bending the cost curve. So I'm totally aware of Mark's efforts and others' efforts in the cost plus space.
So our chair asked us whether we're supportive. I certainly am supportive of investigating. The other quick question is as I understand it, if my school district, enrolls in the, Array at RX, but I don't have any kids in school, because I'm in that zip code, I would have access to the program. Is that right?
Yeah, I think you're conflating two programs, but essentially, if your school district elected to use the PBM services for its public employees or for the employees of the school district, they would have a contract that addresses the management of their pharmacy benefit, and that can be done and could be done through the school district signing the IGA and then a participating program agreement that basically spells out how that pharmacy benefit is going to be administered to serve the unique needs of that school district. The discount card program is usually administered at a state level. It's not administered at a particular group level. So the state would elect to offer this to all the residents, or whatever eligibility requirements, like all state employees or employees of state facilities or state-run or publicly funded entities would be eligible, regardless of where they reside. And then they would use, obviously, as someone pointed out, a zip code that was demonstrating that they had a connection to New Hampshire.
So and this on the Ray RX card, if the New Hampshire enrolls in it, are we eligible to include a small number of adjacent Maine zip codes, Massachusetts zip codes, or New Hampshire or Vermont zip codes?
So as I said before, it is possible that we would just have them utilize their employer's address and zip code that are reflective of that New Hampshire zip code. And that would allow them and afford them the ability to access the program.
So basically, Trevor, the real eligibility, the critical piece to it is the zip code that they reside in the state of New Hampshire. It's not predicated upon their state employee being part of a school district or anything as far as their.
Correct. That's correct.
Thank you. Yeah.
Okay, great, thank you, Trevor. Any other questions?
No,
No, you
very
guys,
perfect.
okay. Thank you again, Trevor, for all your time. I know it's early in Oregon.
Yeah.
And we experienced an earthquake and you didn't have to.
Well, hopefully my presentation wasn't additionally earth-shaking or shattering. So hopefully you're all safe. And I thank you again for your time. Thank you.
Appreciate it. Yeah,
Thank you.
Okay, I think at that time we'll open it up to public comments. Say,
Yeah.
yeah, of course. I didn't have time to circulate it beforehand.
I just sent it to you this morning.
Yeah, no problem.
Good morning, everyone. Sam Hollmeyer here with PCMA, which is a trade association for pharmacy benefit managers. I'm here today. During the public comment period to talk about our comment letter related to the 2024 annual report. I do want to start off by saying, we fully support the efforts to reduce prescription drug costs and then safely making sure patients can access these medications. But in our comment letter, I included what is currently in statute as it relates to the PDAB. But PCMA and our members just believe that some of the statements, studies, or citations were just things that the board members might have never really discussed and included in the report. And I did outline some of those, or most of those, in bullets. So it is a little bit lengthy, but to summarize, we just think the report should begin on page 15, which is titled the Annual Prescription Drug Spending Analysis. And we just think that some of the stuff at the beginning is unnecessary as it relates to this, what's in statute. So again, I outline all that. I apologize for getting it to you all just now, but please take your time to review it. And I'd be happy to answer any questions either now or later on as you digest the material.
At least the time to digest it. So thank you for the report. Again, appreciate the. I think one of the things for us to do is the takeaway is to review the letter. At that point in time, based upon the feedback from the board, what I'd like people from the board to do is go through the letter individually, not collectively. Individually, you can send comments back to our executive director, Mr. Williamson. And at that point in time, he and I can talk about cars maybe following up in February.
Sure. Yeah, my contact's at the bottom, but you can also. Thanks.
Thank you.
Thank you.
Okay, anybody on the chat or joining virtually have any comments? Once, twice, okay.
And also remind people, we agreed last time to do a 3-hour board meeting, so just people understand what's time wise. To go from 9:30 to 12:30, so we'd have enough time to listen to the presentations like our ARX and so forth. I want to commend Mr. Williamson for your annual time with us. It's amazing, it's gone by so
Mary.
fast. Mary?
Mary, you have something you would
Mary?
say? Allow mic, hold on. Okay, I just allowed your mic, Mary.
Hey, Mary?
Yep.
That's one way to shut me up, guys. I think that was a really great in-depth presentation that we got from Array RX. I will point out what's probably really obvious to everybody in the room. I wear multiple hats. So on behalf of state employees that are contractually negotiating our benefits, if we don't come prepared, if we decide, or if you decide that this is a good way to go, and we don't have all the answers for the level of detail people are going to need to know whether or not this works for them and vote on it, it's all for naught. So to that end, I think as we talk about telework, people working and living out of state, people traveling, whether or not mail order still works, because it's not just cost savings for us today, it's also something, a way of life and a convenience. Those are the things I think we need to make sure we can answer, or you can answer, somebody can answer. Just thought I'd throw that out there.
Mary, thank you. Can I just clarify real fast that we are not exploring PBM services. This is specific to the discount card. What specifically would you be negotiating related to that? Are you able to speak to that a little bit more or no?
So yeah, so the health benefits are part of the contract with the state
Got
and
it.
state employees and all of this. So if you were to change that in any way, it would have to be voted on.
Okay.
So that's a really good point, Mary. Definitely the mail order residency, I think that's one of the things we talked about before. But how does Good RX now fit into your negotiations with the state employees?
It doesn't, not at all. My point being, if your thought process was we were going to change the medical benefit, or that would be the recommendation, to change the benefits so that we are not using Express Scripts currently. And we used Array RX in lieu of. I don't know why we would do both. I don't know if that's the trial methodology that might come about. I just wanted to, if the thought is this instead of that we're prepared for.
I think the thought I had, Mary, was this versus that. It's this versus Good RX.
Well,
That's kind
people
of
can still use Good RX. This is just another offering. We're not changing the pharmacy or medical benefit or suggesting a switch in PBM services. But I do hear you on, if that were to be contemplated in the future, that is a consideration we would need to discuss with the state employees union, and then be able to respond appropriately to the questions that would be asked. Okay.
Absolutely.
Yeah, I didn't know for sure what direction you were heading, so I wanted to ground level speak up.
Got it.
I guess what I was trying to get to, Mary, my comment was the fact that I get very nervous about making any changes. And I get nervous about working with an entity I haven't worked with before. So I thought the discount card, my thinking would be a simple, put your toe in the water without having a lot of commitment on our side, outside of the fact that we're going to extend the card to all the state residents, if you will. And depending upon that, and depending upon union and so forth, we could then move into another direction or move into other services they offer. But I think one of the things I'm really leery of is how do we build a relationship with an organization to begin to feel what it's like?
Yeah.
Before we go further. But you raised a really good point. We're not talking about PBM services and touch anything to do with express scripts or anything of that nature
Okay.
at this point. That's probably 4 or 5 years down the road.
Yeah, so I just wanted to add, I mean, that's my concern that I brought it up, but Mary brought it up more eloquently and succinctly. And I think I appreciate what our chair said about what's the difference between that and Good RX. So it makes me, I've evolved quickly in thinking about, well, how might this be disseminated from the board as a recommendation or an endorsement? I think I consider these types of events as disruptors. They're sometimes referred to, this is a disruptor in trying to privatize or independentize from insurance, access to prescription drugs and discount. So how might that come from the board as a recommendation, knowing that it's orthogonal from the employee benefits plan, but as a state-funded agent, as a state-funded entity, we can't ignore the fact that if it does have a negative impact on the economic function of the employee's benefit plan, that we have to consider that too. So I think Mary brings up a point in a different lens than I was initially thinking of it. So we're into some balancing act that we need to be thoughtful about how this message comes from the board. That I think it can still help citizens, but we need to consider the advantages and disadvantages.
Mary, what's the sequence of events? When will the state employees' contract essentially be finalized for a vote?
That's $1 million question, my friend. We haven't gone officially back to the table yet with the changeover in governors. I think they've comprised their team. We've had our team ready. Our contract ends in June.
So my sense of the group here is that we are in an investigative mode, not a decision mode. And, you know, it would be clear to me that if we were talking about a vote in March or, you know, some kind of imminent deadline, there would be no hope that we could make a recommendation that would fit in. We just are not there yet. If we're talking about something that might be a change proposed for the, let me just presume the calendar year 2026, then maybe, you know, we might try to be cognizant of what the deadlines were that we might be trying to meet. I think immediately we're just saying this was an interesting presentation. Let's talk about it a little bit more.
And I want to be clear, at least for myself, all we're talking about at this point in time is discount card.
Okay.
I'm not talking about PBMs, I'm talking about nothing more than just a discount card.
Right. Which is authorized in our legislation.
Yes.
Exactly.
Yeah, this would be an additional something, not in place of something. So that's not, you're not taking anything away. We would have no argument. But if down the road.
Right.
Yeah, and down the road, it's probably a long road, Mary.
Probably. Maybe I retire by then.
You know, along the way, just one of the things I think we heard from folks is, what is the board doing? And I think this is one of the ways to show we are trying to do something. What something is, I think people need to investigate what that is, what the downside is. I see a lot of upside, but I don't know what the downside is. I think that's what Mr. Williamson has to do, is try to find out, like you said, investigate, talk to other states like Nevada, Connecticut, and say, how did it work for you? You got a discount card. What were the pros? What's the cons? And do our due diligence.
Yeah.
At this point. I want to say thank you for bringing it to our attention.
Yep. Thank you, Mary.
Thank you, Mary.
Yeah.
You know, this could, Mary, you're on the, I think you're on the advisory council.
No, Rich is.
You know, maybe something to think about, as we investigate this. Maybe this is a thing to bring to the advisory council, asking them for some input and saying, you know, what do you guys think? What's your feedback?
I agree. And I will alert our negotiation team that this is something that you guys have as a presentation. let you know
Yeah.
that I'll just, yes, and Rich is the representative on the advisory committee. I will be his delegate periodically, but
Yeah.
I'll still be the mouth in between.
What I found was very interesting was a couple of comments that Trevor made. One is they don't sell the data. And, you know, living in New Hampshire and being what we are with so protective of individual data, that caught my attention real quick. Because we have in our constitution, again, be ensure that any data that's collected by any kind of governmental entity is not being shared. So that to me helps immensely right there, because that's one of the things I was thinking about, okay, we can't provide data. So if we're contracting with an entity to a contract with the state, in essence, we're bound by that. That was the first thing I heard. And the other side of the coin is looking at what I call pharmacy deserts. Is how do you help out some of the smaller pharmacies in these rural areas that really are having a difficult time, because if our state residents don't have access to pharmacy services, they have to drive that much farther. That's going to be a burden as well. So those are two things that's my takeaway from it, which caught my attention to why you can go down this road.
Mhm.
I think it's,
Okay,
if not,
anything else?
12:20.
Okay.
Anybody opposing to adjourn? No? Okay. All those? Thank you.
Yeah.
Thank you.
All right,
Thank
thank you,
you.
everybody.
Yeah.